Yeah, it's a pleasure to have all of us from, every part of the world joining today. As I said earlier, this is organized by VOSH International, the Arclight Project, University of St. Andrews, in collaboration with Optoglobe, and it is themed Introducing the Arclight. It's a pleasure to have all of us here today. So I would very much um, like to introduce us to our speaker. We are delighted to have our speaker, Dr. Andrew Blaikie. He will join us today for a wholesome experience of knowledge exchange, and the project is to raise awareness on optometry, ophthalmology, and eye health care. So I would read our speaker's biography, and we would start in earnest. Meanwhile, can I interact with any other persons here? It would be a pleasure to hear from you. How are we all doing? Can I be heard?
Yes.
All right, thank you very much. All right, it's a pleasure to have you, Dr. Andrew. So I will just read your profile and then we start. Thank you very much. So Dr. Andrew Blaikie is a consultant ophthalmologist with the NHS in Scotland and senior lecturer at the University of St. Andrews School of Medicine. He holds an honorary professorial position, with the London School of Hygiene and Tropical Medicine, as well as being a senior lecturer at the University of Rwanda. He completed his medical training at the University of Edinburgh with subsequent ophthalmology specialization in NHS Fife, Scotland. His extensive experience in pediatric ophthalmology includes a fellowship in Brisbane, Australia, and serving as Director of Pediatrics at CCBRT Hospital in Tanzania. As clinical and teaching lead with the Arclight Project, a social enterprise based in Scotland, he has focused on developing, implementing, and evaluating low-cost ophthalmic devices for use in resource-limited settings. This work on frugal technologies has positively impacted eye care delivery in challenging environments across Africa, with over 40,000 devices now distributed globally. His research and teaching activities has attracted multiple grants and awards, including recognition as NHS Scotland's Global Citizen for 2024, as well as Frugal Technology. Dr. Blaikie is active in the public understanding of cerebral visual impairment. Through his work, he wishes to grow further collaborations with partners across all low and middle income regions to enhance eye care. Thank you very much, Dr. Blaikie. It will be a pleasure to have you on board. Thank you.
Thanks, Ita. Thanks very much, Optoglobe and VOSH for inviting me and setting up this meeting. It's, I really enjoy being able to meet other people, even if online, and talk about the work that we've been doing over the last few years, trying to strengthen eye care in resource poor settings. So the Arclight Project is a social enterprise. We're based in the University of St. Andrews in Scotland. And really our role is to try and enable those that are already working in low resource settings to equip, train and empower them to support healthcare workers to be able to more confidently diagnose and manage eye, as well as ear disease, because the Arclight device is an otoscope as well as an ophthalmoscope and an anterior segment loop. So really, we're thinking about frugal technologies, both training and diagnostic tools to try and improve healthcare. And we're very much driven by this idea of the inverse care law, whereby the greatest burden of disease tends to be found in regions of the world with the least access to training, the least access to equipped healthcare workers with the knowledge to know what to do with different diseases presenting, and so that's one of our main motivations. And I work with this gentleman here, William. William is an optometrist actually, but also a very talented and imaginative and creative designer. And he originally had the idea for the Arclight device around about 12 years ago. For the last 10 years, William and I have been working quite closely together, refining it and developing new tools and teaching tools. And really what we've been focusing on are the barriers to accessing good training and good diagnostic tools. And these kind of barriers include tools being expensive, the need for replacement batteries and bulbs, the fact that these diagnostic tools tend to be quite easily broken. They're often unnecessarily complex. They often need to be plugged into mains electricity. And for all those reasons, they're not so easily accessible in lower resource settings. And so we've been trying to address the cost issues, trying to make devices consumable free, trying to make them more robust, simple to use, highly portable, yet still very effective, and ideally then suited for low resource settings. The team's grown over the last few years. I have Obaid Kusha, who's a lecturer from Afghanistan, Fiston Katema, who's ophthalmic clinical officer from Rwanda, Immaculate, who's an ophthalmologist in Uganda, Ian, who does a lot of our video work and photography, Veronica, who's an academic in medical education, and Clive, Frank, and Peter, who are senior members within the School of Medicine and University of St Andrews that are supporting our work in St Andrews. And Helena, who is our new project manager, and she kind of oversees the whole program and the direction that it's going. So the team's grown over the last few years, and we're able to do quite a number of different things. John Sanford Smith is an ophthalmologist who really, he's the one that brought William and myself together. John, he's worked in Africa and Asia as an ophthalmologist, and he wrote lots of different books. Some of you may know them, Eye Diseases in Hot Climates. He really started to write down the approach to managing eye care in these settings. And he's a very renowned and, you know, in the grand scheme of things in eye care globally, very, very well-known and credible character. And John really has been a great supporter of the Arclight Project over the last few years. And he certainly brought William and myself together to work together in the Arclight Project. Now, the Arclight's an unusual device in that instead of having a filament bulb within the handle of the direct ophthalmoscope, which projects up onto a mirror and then shines the light forward and the user looks over the top. Instead, the Arclight has a small LED right on the surface of the device, and that then simplifies the engineering of it, and you look straight over the top of the LED in the Arclight direct ophthalmoscope and can see into the back of the eye quite simply. You don't even need any lenses to do that. And this is how the device has evolved over the last few years. And because it uses an LED, it doesn't need much battery power to keep it lit. And so, in fact, you can have a very small lithium battery inside, which itself can be charged by a surface-mounted solar panel. So the nice thing about the Arclight device is that it uses an LED, which will never break, and the lithium battery can be charged by solar. So you don't really need to plug it in. As long as you leave it by a window or just leave it sitting outside for 2 or 3 hours, it will charge nicely in the sun and work again. And this is how it's developed over the last few years. And now also with the Arclight device, it comes in a packet, which has a visual acuity chart. for distance and for near. It has the speculator turning it into an otoscope, a little instruction leaflet, the charging lead if it's not very sunny, and a little clip which allows you to attach it to the mobile phone so as you can record pictures and videos that you would see with the device of the front of the eye and the back of the eye. Because the Arclight device isn't just a direct ophthalmoscope at this end, it's also an anterior segment loop at this end, and with the addition of the speculum, an otoscope. And it comes in this little packet here, which is nice and compact. You can carry it in your pocket or put the lanyard through here and carry it around your neck and have it always available to yourself. So devices is certainly one part of the Arclight project, but training has become a big part of our work as well as performing implementation research and evaluating our workshops that we deliver, as well as doing advocacy, collaboration with different organizations such as yourself, networking with the supranational organizations such as the WHO and the IAPB to try and influence policy and strategy and get this frugal technology out there in the hands of people who are in low resource settings diagnosing eye and ear disease. So I'll just start with the devices then. So the Arclight is actually just one of a family of devices that we have available and that we are developing. And the Arclight is ideal for your mid-level eye care worker and also your general nurse or general doctor. But at the community level, we've developed two different devices, really for anterior segment examination, which is the Wilson device, as well as a device called the Arclight Zero, which allows community level healthcare workers to examine the front of the eye, but also has a direct ophthalmoscope in it to allow them to perform the fundal red reflex examination in babies to identify cataract and retinoblastoma. So there's community level devices, then there's mid-level devices, such as the Arclight device. We're also in the plans next year to develop a retinoscope called Sauron, which will hopefully work just as well as a traditional retinoscope, but obviously be much more compact and lower cost. The Hollow is our binocular indirect ophthalmoscope that we've developed. And we also have a head torch called Alice. And the Hollow is also a very excellent tool for examining ears and looking into the ear canal and looking at the tympanic membrane. And next year, we're also developing cameras to attach to all these different devices. So as you can take pictures and videos without the need to be attaching it to the camera of a mobile phone, which can sometimes be a little bit fickle. So there's the Wilson device, very straightforward. It's just an anterior segment loop with two different lenses, a solar panel, a very bright light, a switch, and actually pinholes at this end for testing pinhole visual acuity. And it's really for anterior segment work in low resource settings, as well as being a very effective otoscope for ear diagnosis as well. So the Wilson device is very much for the bottom of the pyramid of community healthcare workers, village healthcare workers, health surveillance assistants, people working at the lower level to perform primary eye care. And our Arclight Zero, which is a simplified version of the Arclight that we're developing and hopefully going to be releasing next year, will probably supersede the Wilson in time because it also has the ability to perform fundal red reflex from babies, which we think is an important ability or function of community level healthcare workers to be doing. And then the next level is the Arclight, and at the top we have the binocular indirect ophthalmoscope. So kind of three levels of devices. And here's a quick video showing the binocular indirect ophthalmoscope that we've developed. We hope to release this early next year. It will be roughly £100 in a low resource setting, probably cost £30 300 or so pounds in a high resource setting. And we've done studies with the device. We show that it works just as well as a traditional, expensive, big, bulky binocular indirect ophthalmoscope. And I use this in my NHS practice the whole time. And you can diagnose retinopathy of prematurity with it, diabetic retinopathy, and all the other different posterior segment eye diseases. So there's the binocular indirect ophthalmoscope, the Arclight, and the Wilson device. And hopefully, as I say, we'll have a retinoscope in the next year or so as well to complement the family of devices. This is the Sauron here, the retinoscope. We're also, playing with different camera devices for mobile phones, and that's the head torch Alice. And one project we've got on the go this year in Uganda is evaluation of a low-cost tonometer called the Newton. And the Newton attaches to the anterior segment end of the Arclight with the blue light. And we have 4 different brass weights which go on the Arclight device. So it's a bit of a mixture of the Schiotz tonometer and a Goldman tonometer. Patient needs to sit facing upwards, and you put the normal, typical Goldman prism onto the surface of the cornea, and you look at the Myers to decide whether the pressure is exactly the same, whether it's higher, or whether it's lower. And you change the weight of the brass weight to identify which range it's in, whether it's less than 15, 15 to 20, 20 to 25, 25 to 30. Other devices we're developing are a laser for the binocular indirect ophthalmoscope, a therapeutic laser for retinopathy of prematurity and diabetic retinopathy. And we've spent quite a lot of time over the last 2 years with our physics department looking at different low-cost, off-the-shelf lasers, which we hope to be able to develop into a therapeutic laser to attach to the binocular indirect ophthalmoscope, which we hope to be able to attach to the binocular indirect ophthalmoscope. So as this becomes not just a diagnostic tool, but also a therapeutic laser tool for retinopathy of prematurity and, importantly, diabetic retinopathy. So that's a quick summary of the devices that we have been developing for the last few years. Moving on to some aspects of the training that we deliver. We have a whole range of different training materials, from handouts such as the ATOMS cards here, which describe all the different eye diseases that you might find in a low resource setting, as well as handouts that we might use in a primary eye care setting. And these are complemented by videos as well as mobile phone-based applications and simulation eyes here that we use for training and then testing participants in workshops. So we would provide them with a range of different simulation eyes that have labeled pathology within them, such as glaucoma or diabetic retinopathy. And then at the end of the session, we give them numbered simulation eyes to see if they can identify the pathology and prove to us that they can use the device effectively. And so the simulation eyes are an incredibly useful way of getting people to understand what's going on and demonstrate that they can actually use the device, identify clinical signs, and make a diagnosis. And you can see here on the left, that's the simulation eye. And here on the right is real examination with the Arclight device. And you can see that the examinations are extremely similar. So it's a very nice emulation and simulation of a normal examination. And the simulation eyes we can use not just for back of the eye pathology, but also for the fundal red reflex test. So here we have mimicking some cataract in the simulation eyes. Here's a normal examination with the normal kind of yellow-orange reflex that you see in the fundal red reflex test. There's coloboma for instance, in this simulation eye here. And then finally, in these pair of simulation eyes, we have a kind of a gray opacity that might represent a retinoblastoma or a cataract. And so that's one that's one form of simulation eye that we've developed, but we've also developed simulation eyes for the binocular indirect ophthalmoscope that have hemispherical fundi at the back. And in these simulation eyes, we have all the clinical signs of diabetic retinopathy, retinopathy of prematurity, cerebral malaria, and sickle cell retinopathy, as well as non-clinical symbols such as the Leah symbols. And so we can run now workshops with the indirect ophthalmoscope and these simulation eyes, which can take people through how you use an indirect ophthalmoscope, but then importantly, how you interpret the clinical signs at the back of the eye, whether a patient has sight-threatening retinopathy needing referral, or whether a baby has retinopathy of prematurity, threshold retinopathy of prematurity needing laser or anti-VEGF injections. So we're working now also with a computer games company called Conglomerate Games, developing mobile phone-based training applications, and we hope to complete that project next year. So for instance, here's an example of one of them, a pupil testing application whereby you can demonstrate on the phone how to test pupils correctly. And as I said earlier, in the Arclight package comes a little clip which you can put onto your mobile phone, and then you can attach the Arclight nicely and easily to the phone, and then the camera of the phone becomes like your own eye, and it will see exactly what you would see. So for instance, you might see some anterior segment disease here, such as this ulcer, rubeosis in diabetes, coloboma in a fundal reflex, or the optic nerve in direct ophthalmoscopy. And this opens up the opportunity for a bit of telemedicine, as well as really important training opportunities. Because here we have the Arclight attached to the mobile phone, and I'm able to demonstrate to a group of students who are standing behind me exactly what they're going to see when they perform direct ophthalmoscopy and look into the back of the eye. So it's a very effective training tool, as well as a useful diagnostic tool for telemedicine purposes. And I can also cast the image from the phone onto the screen of a laptop or a larger screen. And then a very large group of students in the room can see exactly what we are doing. And as I said, this does open up the opportunity for telemedicine by attaching it to the camera of a phone. So next year, we are thinking about developing a dedicated camera that will clip on to the phone. And that'll be a USB camera that they would then run into a laptop or a tablet or even your mobile phone. And that would give very consistent anterior segment video, such as here, or back of the eye, optic nerve images, or macula or retina, or blood vessels. And so images can be transferred around using different encrypted platforms to share information from a remote clinic to maybe the base hospital. And here's George. He's sent a picture. He's an ophthalmic clinical officer in Kenya, and he's sent a picture of the back of the eye here of the optic nerve to the main ophthalmologist at the hospital, and she can see clearly that this patient has very bad optic atrophy, and unfortunately, there's not going to be any opportunity to fix this problem that the patient has. And then you can actually show it to the patient as a patient education tool as well. So these are some of the areas that we've been developing in the training sphere between workshops, handouts, simulation eyes, mobile phone-based applications, and different training videos that we've developed. And then when it comes to kind of the implementation science and doing research, there are quite a number of different papers now being published in different journals on all the different devices, as well as the simulation eyes, and the visual acuity chart. So everything's being evaluated to make sure that this is not a compromise. These devices work. They're just as good as traditional devices, even though they're cheaper, even though the engineering has been simplified, even though they're very small, even though they're portable, even though they're solar powered, they work just as well as traditional expensive tools. So for instance, here's a study here from Dundee, one of our local universities, where they showed that the Arclight actually was a superior tool for training medical students how to perform direct ophthalmoscopy. Here's Professor Moin in Pakistan, and he showed a very similar finding amongst his medical students in Pakistan. Here's a study from Malawi comparing the Arclight to a traditional direct ophthalmoscope for performing direct ophthalmoscopy. And again, the Arclight performed just as well as the traditional direct ophthalmoscope in identifying glaucoma and diabetes in simulation eyes. And similarly, again, in Pakistan, Professor Moin here is showing that the Arclight device is an excellent tool for screening for diabetic retinopathy to identify people in the community who would benefit from coming into the main hospital for further treatment. This study from Malawi demonstrates that the Arclight device is comparable in function to the traditional direct ophthalmoscope for identifying fundal red reflex abnormalities such as cataract, retinoblastoma, coloboma, and other diseases like that might be present in a newborn baby. And this has been further taken on by a team in Tanzania who have implemented this in the community, and they showed that it was a perfectly doable task to train community nurses to use the Arclight device to then examine babies and infants at birth and during the immunization program to identify eye disease amongst them and refer in to the hospital. And another study here from India, very similar, using the Arclight device in a high pathology clinic to identify different eye disease, even squint or refractive error, not just cataract and retinoblastoma, by interpretation of the Bruckner reflex for amblyogenic risk factors. And there was no difference in a naive kind of young medical student using this and a quite experienced consultant using the Arclight device in examining patients. So it's a very effective tool for a quick screening examination to identify eye disease. And these are the different types of Bruckner reflex or fundal red reflex abnormalities that you can see with the Arclight device examining children in this high pathology clinic in India. And very recently, we published a paper in the Indian Journal of Ophthalmology with an American team who again showed that the Arclight device was excellent at identifying a whole range of pathologies in a pathology-rich clinic, identifying cataract, retinoblastoma, normal optic nerves, unhealthy, atrophic optic nerves. All these pictures and videos that you can see are all taken with the Arclight attached to the camera of a mobile phone. These are exactly what you see with the Arclight when performing direct ophthalmoscopy, and all these different pathologies such as optic nerve hypoplasia or myelinated nerve fibers there. So a nice study there published in the Indian Journal of Ophthalmology. And here's a paper that's evaluated the Logmar 3-meter EDTRS chart, which comes in the Arclight packet. That all fits there together. And we showed that the visual acuity chart's just as effective as a very large, expensive traditional EDTRS chart. And also in the package, there's this little near card for near visual acuity, and on the back of that, a range of different E's. And you can make little pinholes in the card, and then you can test pinhole vision with that, as is being shown there. And then the simulation eyes, we've shown them to be just as effective and just as good a simulation as much more expensive simulation tools that you would plug in and having a big mannequin head. And we showed that, in fact, that when people can examine these, they prefer this simulation. It's a more of a realistic simulation to real examination compared to the much more expensive simulation eyes. And also the binocular indirect ophthalmoscope simulation eyes we're using now for training people to do laser in diabetic retinopathy and retinopathy of prematurity. And then coming to the binocular indirect ophthalmoscope, we have a number of different studies published and being developed at the moment, showing that this device is just as good as much more expensive traditional devices that you would wear on your head and plug into the wall that literally cost thousands of pounds. And this paper here is just demonstrating the technique of attaching the Arclight to the phone and then casting the picture and video onto a big screen for a whole bunch of students to learn with. So it's a fantastic training tool as well as a tool for telemedicine. And this very recent paper that we've published was to do with the fundal red reflex examination. I'm not much of a fan of the red reflex examination because it's the reflex doesn't really look red in people that are not white. So in black sub-Saharan Africans or in Asian people, the reflex looks more yellow and orange. And it does create quite a lot of confusion when we're teaching and training, calling it the red reflex, when in fact it doesn't look red. Normally it doesn't look red. So we published this paper recently whereby we took some videos of people of different racial groups, and we asked people to look at the videos and decide what color they felt they were, as well as objectively measuring the color. And as it turns out, as you would expect, many people said it looked yellow or orange or brown, and very few people said that the reflex looked red. So I'm quite keen on trying to decolonize this name and call it the fundal reflex exam rather than the red reflex examination. And so all this kind of research and all these different training tools are really all coming together into developing workshops and implementation at the community level, trying to improve primary and mid-level eye care in low resource settings. And we work with a number of different NGOs over the last few years trying to do this. So typically what we do is 1 or 2 lead trainers go to a region. We train up 10 or 20 trainers in a training the trainers program. And those trained trainers then go out and start delivering workshops themselves on how to use the Arclight device, how to examine these simulation eyes and make sense of the clinical signs. So as these primary and mid-level healthcare workers who previously didn't have the knowledge or the skills or the equipment in eyes can leave the workshop much more able to go about making a sensible decision about what type of eye disease is presenting to them in their health clinics in the community. And therefore, several million people can be provided with reasonably good eye care services at the community level by this cascade of trained trainers activity. And this little video here is just an example of what a workshop might look like. This is being delivered by trained trainers to community level healthcare workers, different stations that the groups go around. And for instance, this station was looking at primary eye care procedures such as cleaning an eye, irrigating an eye. Here, one of the trained trainers is taking the participants through how to take a history. Here, this ophthalmic clinical officer from Tanzania is teaching how to test visual acuity using the 3-meter visual acuity card. And in here, this ophthalmic clinical officer is training these community healthcare workers to use the Arclight to examine the anterior segment of the eye and identify corneal ulcers, cataract, trauma. And one of the trained trainers here is explaining about the pupil examination and the importance of the pupils being black, round, and equal, and constricting to light when you shine light on them. And then finally, in this community kind of workshop, the trainer is showing them how to perform the fundal reflex examination to identify cataract and retinoblastoma in the simulation eyes, and hopefully for them to be able to go out and use this in the community to identify disease. And this is all done in the context of a busy eye camp. And so the healthcare workers can then go into the eye camp and work with the trained ophthalmic clinical officers and see disease and understand how to make a diagnosis and understand what glaucoma looks like, what diabetic retinopathy looks like, what cataract looks like, and they become much more useful and effective in the community when they leave this training session. And we've evaluated this work in Rwanda with my PhD student who's based there, Fiston, and published a number of different papers on these evaluations of the workshop. And importantly, in interprofessional education, where different professional groups can learn from each other about their different roles. And for instance, here is an ophthalmic clinical officer student teaching general clinical officers about eye care. We've also delivered workshops using the indirect ophthalmoscope in Indonesia on retinopathy of prematurity, and increasingly more recently on diabetic retinopathy. And here's Obaid, our lecturer from Afghanistan. And this is him leading a workshop of optometrists actually in Kenya, in Sabatia eye campus up near Lake Victoria in Kenya. And he's teaching the clinical officers how to use the indirect ophthalmoscope to examine the simulation eyes, identify non-clinical symbols, such as Leah symbols at the back of the eye, but then go on to be able to identify the different clinical signs of diabetic retinopathy to identify sight-threatening disease, which requires to be referred on for laser treatment or anti-VEGF injections. So these simulation eyes and training tools and workshop designs are very effective means to quickly get people up to speed in how to use a device and how to diagnose eye disease with it. We strongly feel that diabetic retinopathy screening in these low and middle income settings is probably best done with a human being with a binocular indirect ophthalmoscope who's seeing the patient, because there's so much other disease in that patient population, such as cataract, glaucoma, retinal detachments, corneal scars, that we feel that a human being should be doing the screening to identify these different diseases and actually really perform a consultation rather than using imaging devices such as cameras. So we're really keen that if we do train and implement healthcare workers, optometrists, and ophthalmic clinical officers with the indirect ophthalmoscope and with the Arclight, that they can go then to actually go into high volume medical clinics where patients with diabetes are and start testing visual acuity, testing their pupils, looking at the front of their eyes, dilating the pupils, looking into the back of the eyes, and to see if they've got cataract or glaucoma, but importantly, whether they have sight-threatening diabetic retinopathy that requires referral to the eye clinic for laser treatment and anti-VEGF. So we'd love it if more eye care workers could embed themselves in these high volume NCD clinics, these non-communicable disease clinics, where many patients with diabetic retinopathy are attending, to try and identify sight-threatening disease where there's new vessels at the optic nerve, or if there's a tractional retinal detachment in one eye, but the other eye is still preserved, if there's hard exudate and edema at the back of the eye, or whether there's other eye disease, such as glaucoma with a cupped optic nerve. And so we'd love it if the eye departments could collaborate more with the medical departments using our tools to diagnose disease. So that's just some examples of the research and implementation work that we've been doing over the last few years. And then finally, to finish, some of the advocacy that we've been doing. We work with many different training institutions and academic institutions and different eye care NGOs. And as a consequence, in fact, You know, the Arclight device is now in many different countries in the world. We think there's over 45,000 devices out there now, mainly in sub-Saharan Africa so far, but hopefully in the future, many more in areas of Asia and in Latin America as well. So this image kind of summarizes all the different things that we're up to. And you know, I'm delighted to be given the opportunity to talk about our work, and that would be great if we can work more together in the future in these different areas. So here's some of the social media handles that we have, the website address, and you know, these QR codes will take you to our YouTube channel as well as our Arclight Project website. So many thanks for giving me the time to talk. I hope I haven't spoken for too long, and that's been a useful introduction to the Arclight Project.
Thank you very much, Dr. Andrew. That was a very insightful session. Thank you for that session. So for those people who joined in while he was talking, he was just speaking about the usefulness of the Arclight for diagnosis and further treatment of eye health diseases, and the need for further collaboration between optical departments and medical departments. And as he said earlier on, he did not speak for too long, and I know a couple of us here have a lot of questions to ask. So, Dr. Andrew, would you be entertaining questions?
Yeah, of course,
All
yeah.
right. Thank you very much, Dr. Andrew. So if you have a question, please indicate, so I'll just have you speak with Dr. Andrew. If you have a question, please. All right. Okay, I think I have okay, we have a question on the chat box.
Hello, Dr. Andrew. I have one question.
Hello.
Hello.
Is
I'm
that
audible to. I'm audible.
Okay.
Hello, I am audible.
Nizam, we can hear you. Please go on, Nizam.
Okay. Can an arc light be safely used as an alternative to a retinoscope and ophthalmoscope?
Can an arc light be used as a retinoscope?
No. Can an arc light be safely used as an alternative to a retinoscope and ophthalmoscope?
So the arc light is a direct ophthalmoscope, anterior segment loop, and otoscope.
Yeah. And also it is and also it is safe for us, safe for eye.
I'm not quite catching the word before eye. You said something before eye. I didn't quite catch what that was.
Is an arc light as a safe for eye as a retinoscope and ophthalmoscope?
Is it safe?
Yeah.
Yes, it has CE mark, UKRI mark, FDA approval. I mean, our ophthalmoscopes are not dangerous. It's just a light looking in the back of the eye. There's no safety concerns with direct ophthalmoscopy. It's a very safe class 1 device as it's known. So it has all the approvals and regulatory settings in place. So I wouldn't be concerned about that. It's just an LED light. Very safe, no problems.
Thank you, Andrew.
Thank you.
All right, thank you very much. Please, if we have any further questions, indicate in the chat box. I think we have a question from a participant. He asked, what if the instrument, I mean the Arclight, I think he means, is not charging? So I don't understand the context of the question quite very much. What if the Arclight is not charging? That's from Nehemiah Marcus. So, Dr. Andrew, do you have Do you have an answer to that?
I mean, if it's not charging, that would be quite a rare event. It's quite unusual for the arc lights to fail. I mean, obviously, with any device, there's a small failure rate, maybe 1 in 200, 1 in 300 after a year or two might not charge well. But I personally have not really come across many devices that don't charge either in the sun, using the solar, or using the USB lead. So if you're having problems, then by all means, email the Arclight sales team, and we're quite happy to replace devices if there's any concerns with them not working as they should. I put the email address at the top of the last slide there. It says arclightsales@standrews.ac.uk.
All right. Okay, I hope that answered that question. Okay, another question. Is there anything that the ophthalmoscope can do that the Arclight can't?
No, it's the other way around.
Oh, it's the other way around.
I mean,
Okay.
the Arclight's got a very nice anterior segment loop. So you can do a really nice examination of the anterior segment with the Arclight. You can't really do that with a direct ophthalmoscope. You can easily break a traditional direct ophthalmoscope, or you can easily make it run out of batteries or get its filament bulb to fail and then not use it ever again. But you can't do that with an Arclight. It just keeps on going because it's solar powered and the LED. You can't break it.
I have one more question, Andrew. Dr. Andrew.
Hi.
Can an Arclight be as an alternative to a use OCT test when
All right.
we
All right.
connect?
Thank you very much, Dr. Andrew. So we have a
Hello, I am audible.
Yes, we can hear you. Go ahead.
Can an Arclight be used an alternative to a OCT test when we connect a mobile phone?
So you can connect the Arclight to the camera of a mobile phone. So the camera will take a picture in the same way that you'll see with your own eye. But you mentioned something about OCT there, did you?
Oh, I think we've lost him.
Yeah. There are some hands up.
Okay, we have a question from Primrose Magala. Primrose Magala, please, can you ask your question?
Yes, thank you so much. Good evening, everyone. Good evening, Dr. Andrew. I think you're just about to touch on the OCT. Would you be able to go through some of the images, especially for the benefit of the community workers? For example, glaucoma, what do some of those images look like? Diabetic retinopathy and others. If you can kind of go through, maybe have another session just to support those community workers who are getting used to using the Arclight. Thank you.
Yeah, of course. I'd be very delighted to do a more kind of formal teaching session. I know tonight's was very much about an overview of the project and an introduction, but I think it's quite reasonable to think about doing an online workshop showing anterior segment pictures and then the fundal reflex and then fundoscopy of the back of the eye. I'm quite happy to do that in the future.
Thank you, Dr. Andrew.
Ita, I see that someone's put in the chat there asking how you connect it to the phone. You connect it using this little sticky clip, and you stick that clip onto the phone, and then the Arclight simply sits nicely in that little clip, and then you secure it with the elastic, and then it sits on your phone like that. So very simple kind of approach to it. Someone's also asked in the chat, and legally, can the Arclight be used for a clinical purpose instead of an ophthalmoscope? That comes from Enoch. Enoch, it's a very good question, but you know, the Arclight, I know it's called an Arclight, but the Arclight is a direct ophthalmoscope. It's not like a toy. This is a direct ophthalmoscope with full European accreditation, full UKRI, full FDA approval. This is a direct ophthalmoscope. This is what I use in my NHS job in Scotland, in the UK. This is what I carry in my pockets at work. 95% of patients I only use these two devices on to diagnose them in my NHS practice in Scotland. I hope that answers the question.
I also have a question, if I may. Yes, I am, for the colleagues who don't know me, I'm the director of VOSH International. And I'm not an optometrist, but I am fascinated by eyes and vision. In our membership, we have an increasing number of schools of optometry outside Western countries, you know, from the South. So the cost issue that you mentioned and the accessibility once the students graduate is really relevant for us, because buying a standard retinoscope is very, very expensive and unaffordable. So in terms of the production capacity, for instance, we have almost 50 schools of optometry outside the US, in Latin America, Asia, Africa, and in some countries that are really very difficult contexts like Somalia or Haiti, Lebanon, you know, and West Bank, etc. So what is the capacity of the institution to, for instance, deliver the instruments in big numbers? Because I was thinking, you know, this could be a very nice useful tool to give to graduating students, you know, who are committed to go and serve their communities that are outside urban areas, but who don't have the capacity, the financial capacity to get, you know, their first set of instruments. And we have been trying to support Haitian students, you know, with basic trial set lenses and things like that. But what will be the capacity, let's say, thinking big, if we would like to, as VOSH, you know, run a pilot project with some of the most needed schools of optometry and provide these tools to the students, the graduating students? Is there a waiting list, or how does it work?
No, we've got several thousand devices in stock, and we can produce several thousand a month. So there's no concerns about access and volume.
Okay, no, thank you.
So someone's asked in the chat, how long can the Arclight last after being fully charged? Again, that's a nice question. So with the normal Arclight, the Arclight Mark IV, when you switch it on, it only stays on for 90 seconds, and it switches itself off automatically. If it's fully charged, you know, typically, without having to charge it again, it will last for 1 or 2 months. So basically, several hundred, if not several thousand, 90-second uses. But obviously, in that period, you would typically leave it sitting by a window, or maybe just plug it into your computer for 15 minutes, or into the wall for 15 minutes, and then in that 15 minutes, it will be fully charged again, and again last for several weeks. But that's a good question.
Yeah, then we have Dr. Adaku Obia's hand raised, and I think it's good we have her ask a question also, sir, before we proceed with the other questions.
Thank you very
Dr.
much.
Yeah.
Yes, please, I'm here. Thank you very much, Dr. Andrew, for this enlightening session. And Pamija, thank you so much. I wanted to ask some questions, but it's been answered. Some persons asked, and Dr. Andrew has done justice to the questions. So that was why I had to put down my hand. Thank you very much.
Thank you.
Thank you.
So we have a question in the chat from Nizam, who's saying, where can he purchase the Arclight from?
Yeah, so I put the email address into the chat there. So we have 4 different price bands depending on the Human Development Index of the region that the individual or the institution is from. So the lowest would be around 13 British pounds for one of these. And then the highest is about 60. So in Scotland, if an optometry student wanted to buy one of these, they'd have to pay 60 British pounds, but 13 in the lowest. And the other ones are in between. I can't quite remember the numbers off the top of my head. But generally for low resource settings, we tend to supply them in packets of 25. So thinking more about a department or an institution or a class buying 25 of them, because it's not very economical sending one device all the way to Somalia. We are slowly beginning to identify distributors in different countries. So for instance, actually, we've got a distributor in Kenya now for East Africa, which works well. So they have devices there. So they can sell and send individual devices to individuals in that region. We're working hard on trying to get that going in India, as you would imagine, as well. So, but at the moment, typically, if an optometrist in a optometry eye hospital unit wanted a device, would try and encourage them to buy, everyone to get together and buy 25 and then send a batch of 25 at once. That's kind of how it works. But it's important to make sure, you know, they know that they know that you're not like in Scotland or in the UK, to make sure they know what country you're from, because it's basically, there's no profit in selling. It's cost price essentially in the lowest resource settings without any profit. But there you go. That's the answer.
Well, thank you, Dr. Andrew. I believe she had your question. A question from Joseph. He asked, he did not get where you talked about the Arclight in helping in detection of refractive errors. Can the Arclight also offer retinoscopy as well? So Dr. Andrew, that's for you. And okay, we also from Dr. Adaku, do you have distributors of the Arclight in Nigeria?
No, we've no Nigerian distributors yet. If you can find me a reputable one, we'd be interested. Please email me directly. Look, the Arclight is a direct ophthalmoscope, so it's not a retinoscope, but you can identify refractive error in direct ophthalmoscopy by interpreting the Bruckner reflex. I've put some pictures up here. So this is the typical Bruckner reflex. You know, it's darker at the bottom, just a little bit of brightness at the top. If you get a Bruckner reflex like this, which is very light at the bottom and dark at the top, you know that patient is myopic. That's a myopic Bruckner reflex. This one is a very hypermetropic Bruckner reflex, where it's very bright at the top and only a little bit dark at the bottom. This one here shows an esotropia, a left inward turning squint. This eye is fixing and is dim, and the squinting eye is very bright. And so with the direct ophthalmoscope, by interpreting the Bruckner reflex, you can get a sense of refractive error myopia, hypermetropia, anisometropia, difference between two eyes, as well as a small squint, not just the typical absence of a reflex that you might get in retinoblastoma or cataract, which is the standard way of interpreting the fundal red reflex. But by interpreting and thinking more about the appearance of the color of the light, that's the Bruckner reflex interpretation, you can have a guesstimate at the refractive error, even though it's not a retinoscope. So, and I do that the whole time in examining young children. Quick examination with this, you instantly know, oh, they're very myopic, or they're very hypermetropic, or they've got a little bit of a squint, or they've got an isometropia, just quickly by doing that before I've got a retinoscope out in any lenses. It's a very important skill, which all optometrists should be taught. If you find this paper and read this paper, it discusses it and shows it very nicely.
All right. Thank you very much, Dr. Andrew. So we still have some more questions. I don't know if the questions are getting so much, but probably after the next, I would say next 5 questions, we should stop. So Joseph Kalule is asking, does the device perform any other clinical work than a direct ophthalmoscope exam? Actually, other clinical work outside eye care? I think someone had already given him some answer about the device being an otoscope. And we have a question from Richmond, which I also wanted to ask because I got to learn that in Ghana at the Kwame Nkrumah University of Science and Technology, that optometry students have been advised to purchase the Arclight instead of the ophthalmoscope when going into clinicals or their clinical years of study. And Richmond is asking that, does the Arclight have distributors in Ghana? Yes, sir. So those are the next 2 questions. And after these 2 questions, we'll be entertaining only 3 more questions. If you maybe have more, send them to us via mail or directly to the Arclight via mail. Thank you.
So it's interesting. We don't have any official distributors in Ghana, but I know that quite a few people in Ghana buy them in bulk and then sell them on at profit. Ghana is our country with the most Arclights than any other country in the world. They've really adopted it as their as their own device. It's been great. I remember I was traveling in Ghana a few years ago in quite a rural region, and I came across an eye clinic, and I thought I would go in and say hello and give the optometrist an Arclight, and I showed him my device and said, do you know what this is? Would you like one? And he pulled one out of his top pocket and said, I've already got one. So that was in the upper Volta region, I remember. Oh gosh, his name's going out of my head. But anyway, it's got high penetrance in Ghana, and it's great that everyone's adopted it nicely, but without having a distributor. But people have been buying them and selling them on at profit, which is fine. I don't care. That's great for them. And also, we are using it as a dermoscope, so we can use it for skin as well, for looking at skin lesions. So it's really got 3 functions: skin, ears, and eyes. And for the eyes, it's got 2 functions. It's a direct ophthalmoscope and the anterior segment loop. Thank you.
Hello, Dr. Andrew. I have one more question.
Hi.
Can an Arclight use as an alternative to OCT test or fundus test when I connected the mobile phone?
No. So it is not an OCT. I mean, an OCT is a very sophisticated, expensive tool. I mean, you can look at the back of the eye, and if you see exudate, there's probably edema. You could do an OCT on that patient and show edema, but no, it is not an OCT. So don't. It's a direct ophthalmoscope and an anterior segment loop. Full stop.
Thank you, Dr. Andrew.
Thank you.
Okay, so we have Jimin Josephine with her hands up. So Jimin Josephine, please, you can ask your question and be quick about it. Thank you.
Do you mean you can ask?
Andrew, the question is, can you charge the Arclight? Like, can you use it while charging? While you're charging it, can you also use it? That's my question.
I mean, yeah, I mean, you could. I don't know why you'd want to, because it only takes a few minutes to charge and then you can just unplug it. But I mean, you're right, you can have it plugged into a battery and you could use it still attached to the battery, but it only takes a few minutes to charge it. I mean, it could be completely flat and you could literally plug it in, actually only for like 30 or 40 seconds, then it'll work fine straight away. But leave it in for 15, 20 minutes, and it's good then for the next few weeks. So can I quickly, did that answer your question, Josephine?
Thank you very much.
Thanks. So someone's asked there, how magnified is the image with the anterior segment loop? So it's about a 20-24 diopter lens. So it's quite a powerful lens. So it gives a fixed focus at about 5 or 6 centimeters. And so the magnification must be 2 or 3 with that. So it's a nice thing for looking at the front of the eye. You see most detail, and obviously you've got a nice bright light associated with it as well. It's not a slit lamp, but we have done a study actually in Uganda comparing it to a slit lamp, and it actually does very well for most primary eye care pathologies.
Okay, so thank you very much, Dr. Andrew. And I think we'll just be taking, I'm just trying to determine if this is a question. The last question, every other question can be sent in later, because I understand it's about 4 a.m. in Australia. And yeah, it's very late in Pakistan and India. So I think we should be rounding up for the sake of others. Okay, so from Deborah Hassan, she's saying, what if the USB charging isn't working? I think this was tackled earlier on when you said they should always reach out whenever they have an issue with the Arclight, but you could still speak more on that, sir. And Michael Achamfor says, it feels difficult viewing the macula with the Arclight than with the ophthalmoscope. I do not know if that's a question.
I mean, obviously, when you look at the macula with any ophthalmoscope, the pupil constricts because that's where your strongest direct response, pupil constriction response, is found, because the cone photoreceptors are so tightly packed there and there's so many of them. They really drive pupil constriction. So, I mean, it's hard to examine the macula with any device. The Arclight's no different. You try and use low illumination in a dim room to see the macula, but ultimately you need to dilate people to see the macula well. The Community Eye Health Journal this month, I've written an article exactly about that, actually, examining the macula with the Arclight. And I emphasize that it's low light, dim room, or dilate, but the macula is hard to see because the pupil always constricts with any device.
Okay, thank you very much, Dr. Andrew.
Great.
Treasurer Rita, I think you could take over now, and every other question can be sent in later on.
All right, thank you very much.
I think you are muted, Ita. Oh, I think we may have lost him. So like I said earlier on, every other question can be sent to us via mail at optoglobe.optoglobe@gmail.com. I'm just typing that in chat.
All right.
Okay.
Okay. All right. Thank you very much. Thank you very much, Dr. Andrew. Please forgive my poor network. Thank you very much for the questions that have been asked, everybody who has asked the question. Thank you very much to Optoglobe. Thank you to the Arclight, VOSH. So going further, we know we don't have the monopoly of time, so we will not be able to take as much questions as we wish. But then Dr. Andrew has indicated that there is an email address you can ask all your questions to. So please wire all your questions, all your suggestions, all your yearnings to the email address. They will be responded to adequately. Thank you very much, everyone, for joining in. So at this instance, I would be calling to take the microphone Pemije Gadimo, founder of Optoglobe. He would go forward from here to give a little remark before we end the webinar. Pemije, please come on board.
Thank you very much, Treasurer. I'll just be rounding up or concluding for the webinar. Like Dr. Andrew has given us a very good overview about the Arclight as optometrists, optometry students. I hope we take this opportunity. You know, we all know the high costs of the traditional ophthalmoscope and how difficult it is for optometry students to purchase it. So I believe this is a good alternative, especially for those of us who do a lot of outreaches or outreach programs. We could substitute with this, as it's very, very portable, easy to charge in harsh conditions, and it's you know, dust resistant, water resistant also. So I think the Arclight is a very good device that we should all look forward to. Good news is colleagues in Ghana are using it for educational purposes. I think I would recommend, if your school may not have an idea about the Arclight, you could probably walk up to your head of department or faculty head and introduce them to the Arclight, you know. And if maybe they will have more questions, you could give them the email address of the Arclight to Dr. Andrew, so they converse with him and discuss better. So I think it's a good way from here. I can see we have so many participants from different countries. Some came on and came off due to their network issues, and I understand that. I can see everyone from India, from the Democratic Republic of Congo, Pakistan, Jordan, Nigeria, Ghana, Kenya, Uganda, the US, the UK, and so many other countries. I wouldn't be opportune to mention every country. So you could just drop your country in the chat, your name and your country, so we know you're represented, and we round off the meeting. And I think it was a great one with everyone, the last one. And I believe going into the new year, we would all appreciate what we have learned from this. So I don't know, Engineer Maria Arce Morera, the Executive Director of VOSH International, do you have any words for us?
No, just briefly, thank you very much, Dr. Blaikie. This session has been recorded. I think it's a very good idea to organize perhaps next year a more specific training session, and we can invite our faculty advisors from all the different schools that are member of VOSH as well, so they can see the advantages and so on. But thank you very much, everyone, and we will be sending the link of the recording to Pemije to share with the Optoglobe students. Thank you.
Thank you very much. It's been a pleasure.
Yes.
Take care. Enjoy the holidays. Bye.
All right. Thank you very much, everyone, for joining in. And it's on this note, I wish everyone a happy holidays. Season greetings to everyone. I understand this would be the last Optoglobe event for the year. Hopefully, we hope we don't get to engage after this. So everyone has to rest and prepare ahead for the new year. So thank you everyone for joining. Indeed, it was a moment. Thank you very much. You could unmute and just say goodbye, to everyone. And I can see everyone, Samsung from Somalia and every other person who has joined in. Thank you very much.
Thank you.
Bye. Thank you.
Thank you.
Bye, everyone.
Bye.
Thank you, Dr. Andrew.
My pleasure.
Bye.
Bye.
Bye. Thank you. Thank you.
Bye. Thank you very much.
Bye.
Goodbye. Hasta luego. Saludos.
Thank you very much. I'm student at Oni University. I'm happy to participate.
Great.
Thanks, everyone. The link will be sent to your emails. Bye-bye.
Thanks. Bye.
Yes,